Destructive neurosurgical procedures for the treatment of pain have played an important role since they were first developed in the early 20th century. As other non-destructive therapies such as spinal cord stimulation, intrathecal opiate pumps, high-dose opiates, and other medications have been developed and utilized, the use of destructive procedures has slowly declined. In recent years, however, it has become evident that non-destructive treatments are associated with some disadvantages, and it is, therefore, important to reconsider the use of destructive procedures in the treatment of pain. The purpose of this chapter is to give an overview of the current literature on ablative procedures, including dorsal root entry zone lesioning, rhizotomy, ganglionectomy, myelotomy, chordotomy, and others, along with reported side effects, effectiveness, and follow-up outcomes. Studies that involve ablative procedures are limited, but a significant number of case series show that these procedures can be very effective at treating a wide variety of pain conditions in both malignant and non-malignant patients. Unfortunately, there has been a significant emphasis on new techniques and a shift to new, promising therapeutic approaches without a thorough and complete understanding of the existing ablative procedures. Randomized, controlled ablative procedure studies for the treatment of pain will be invaluable in the future. Such studies could lead to improvements in patient selection and surgical outcomes, as well as a greater understanding of the pathophysiology of pain states. Destructive neurosurgical procedures for the treatment of pain remain an important tool in the neurosurgeon's armamentarium. Key concepts for the chapter. A wide array of effective neurosurgical procedures for myriad pain conditions have been developed for the treatment of pain since the introduction of ganglionectomy for the treatment of trigeminal neuralgia in the early 20th century. Destructive procedures for pain relief have decreased significantly in frequency as less invasive, non-destructive treatments such as spinal cord stimulation, new medications, and various opiate treatments have become more popular. Non-invasive treatments have some disadvantages. Therefore, it is important to consider destructive procedures when evaluating pain symptomatology and determining the most effective treatment plan. Ablative procedures have a long history of providing efficacious, drug-free pain relief. There is a paucity in the literature of well-designed clinical trials with or without randomization, although significant effort is being made to incorporate standards of evidence. Future studies should examine the clinical significance of achieved pain reduction and long-term efficacy, recognize the subjective nature of pain with validated outcome measures such as the visual analog scale, which is well recognized, and consider reporting and observer bias and placebo effects, which appear to be more pronounced, especially with the use of invasive procedures. The surgical treatment of pain has been an integral part of neurosurgery since the early 20th century, when Harvey Cushing pioneered the ganglionectomy for trigeminal neuralgia. Over the ensuing years, as anatomic and physiologic knowledge of pain systems grew, new techniques aimed at new targets were developed for an array of pain conditions. Targets have included the anterolateral quadrant of the spinal cord, the sensory and sympathetic ganglia, the dorsal and ventral spinal roots, and decussating extralemniscal fibers, the hypophysis, the thalamus, and the cingulate gyrus. Careful, detailed descriptions of these techniques and their purported efficacy from pioneers in the field established the importance of surgery for the treatment of pain. The invasive nature of these techniques and associated comorbidities, as well as the high degree of technical skill required for their use, led to the development and widespread adoption of newer pharmaceuticals and non-destructive treatments. As a result, the use of destructive techniques in the surgical treatment of pain has dramatically declined over the past few decades. They are being, or have been replaced, with non-destructive techniques and devices such as spinal cord stimulation, intrathecal opiate pumps, newer medications, and high-dose opiates. However, it is becoming increasingly apparent that none of these techniques is free from its own set of detriments. For example, the long-term administration of opioids is associated with addiction, opioid-induced hyperalgesia, cognitive disorders, high costs, and the suppression of the immune and reproductive systems. Furthermore, it is yet to be proven that the long-term use of opioids improves such outcomes as pain relief, functional capacity, and health-related quality of life. Neurostimulation and intrathecal drug administration are expensive and require ongoing battery and catheter maintenance and pump refills. Despite their widespread use and study, their clinical efficacy has not been demonstrated according to modern standards of evidence-based medicine. Given that all three broad approaches to the treatment of pain, destructive, non-destructive, and medical, have matured, and the initial wide-eyed enthusiasm of their introduction is over, it now seems timely to revisit the existing literature and see how the older destructive techniques compare. By doing so, we can develop and implement those techniques that are effective and relegate to history those that are not. In this chapter, we summarize the published data on destructive procedures for both malignant and non-malignant causes of pain in order to determine the level of evidence supporting continued use and help define areas that warrant further study. Therefore, we reviewed human clinical studies that reported outcomes for destructive techniques used in the treatment of non-malignant pain conditions. Reviewed studies were grouped according to the surgical target, beginning with peripheral or first-order neuron targets. We reviewed the peer-reviewed English literature that encompassed January 1954 to May 2019, applied to both malignant and non-malignant pain etiologies. Evidence was classified according to the hierarchy of clinical research design and the grading system used by the U.S. Preventative Services Task Force as follows. Grade 1, evidence obtained from at least one properly randomized control trial. Grade 2-1, evidence obtained from well-designed control trials without randomization. Grade 2-2, evidence obtained from well-designed cohort or case control analytic studies, preferably from more than one center or research group. Grade 2-3, evidence obtained from multiple time series with or without intervention, comparisons between times or places with or without the intervention. Dramatic results in uncontrolled experiments, such as the results of treatment with penicillin in the 1940s, could be included in this category. Grade 3, opinions of respected authorities based on clinical experience, descriptive studies, or reports of expert committees. In total, 192 papers on non-cancer pain and 139 papers on cancer pain were reviewed. Few articles were included in both non-cancer and cancer pain reviews. The large majority of studies constituted Class 3 evidence. Only 25 Class 1 or Class 2 studies were found. 17 of these studies evaluated radiofrequency rhizotomies for different pain etiologies, such as lumbar facet syndrome, cervical facet pain, and type 1 or typical trigeminal neuralgia, whereas 3 examined ganglionectomies for either lumbar or cervical pain. 3 studies, 2 Class 1 and 1 Class 2, evaluated and supported sympathectomy of visceral cancer pain. 1 evaluated the use of chordotomy in malignant cancer states, and 1 evaluated dresotomy technique in the management of intractable brachial plexus avulsion pain. Our database search and secondary review of references located 57 rhizotomy studies that generally concerned spinal or facet pain and facial pain syndromes, and 11 papers that addressed cancer pain. The majority of the studies reported data relevant to either trigeminal neuralgia or lumbar facet syndrome, whereas the remainder evaluated the effects of rhizotomy on a variety of truncal and extremity neuralgias, cervical pain, cluster headaches, vagoglosopharyngeal neuralgia, or cancer pain of various etiologies. Rhizotomy for truncal or extremity neuralgias, or lumbar facet syndrome, can be performed percutaneously with the target being the spinal nerve. Alternatively, the RF electrode can be directed to the nerve innervating the facet as it passes over the pars interarticularis, so-called facet rhizolysis. Since the facet is innervated by the medial branches of the spinal nerves above and below the facet of interest, at least 3 levels of facet rhizolysis must be completed to obtain pain relief. In the studies on rhizotomy for truncal or extremity neuralgias and lumbar facet syndrome, success rates were initially around 60%, but declined on long-term follow-up. Despite the variability in treated pain syndromes, number of sectioned roots, outcome measures, and follow-ups, the results were discouraging enough that the procedure was relatively abandoned and replaced with modified rhizotomies directed at facet denervation for the treatment of lumbar facet syndrome. 4 randomized, blinded, controlled trials compared RF rhizotomies of the medial branch of the dorsal root with the sham procedure or intrafacetal or extrafacetal rhizotomy. Outcome measures and patient selection differed between the groups sufficiently to preclude a meta-analysis. Modest long-term improvement in pain scores in the treated group was observed in all 3 studies comparing rhizotomy with a sham procedure. In the last study, intrafacetal rhizotomy was found to be superior to extrafacetal rhizotomy. Complications were minimal in all 4 studies. Of the remaining 15 papers, 5 are prospective in nature. Proportions of patients with good outcomes varied from 41 to 75% in long-term follow-up. The remaining 7 series are classified as Class 3 studies and reported long-term success rates of 40% to 60%. One randomized controlled trial evaluated the effects of RF lesions of the ramus communicans for treatment of single-level chronic discogenic back pain. All selected patients had previously undergone a failed intradiscal electrothermal, or IDET, procedure and had a good response to local nerve blockade of the ramus communicans. At 1 month and 4 months of follow-up, the treated group showed significant improvement in visual analog scale and medical outcomes study short-form health survey SF-36 scores. Lumbar facet rhizolysis is still being performed for facet syndrome and discogenic back pain. RF rhizotomies were compared with sham procedures for the treatment of cervical pain or cervicogenic headache in 3 randomized controlled trials. 1 prospective Class 2 clinical trial and 4 case series also addressed rhizotomies for cervical pain. The number of patients in each RCT was small, ranging from 12 to 24. 2 of the RCTs demonstrated a significant treatment effect of RF lesions, although 1, an underpowered study, did not. The Class 2 study also reported durable reduction in validated pain scores. Both studies, with long-term follow-up, demonstrated similar median time to recurrence. Cervical facet rhizotomy is still being performed for neck pain. Percutaneous RF trigeminal gangliolysis is a relatively common procedure in the neurosurgical armamentarium and is a long record of success in the treatment of trigeminal neuralgia. The procedure is performed under sedation, during which a radiofrequency needle is placed into the trigeminal ganglion, where a thermal lesion is created. We found no controlled trials that reviewed the treatment of trigeminal neuralgia by rhizotomy. The best evidence consisted of 3 Class 2 and 4 Class 3 studies that prospectively followed patients with trigeminal neuralgia who were treated with RF rhizotomy or glycerol rhizolysis, as well as a large 1,600 patient case series. In a large comparative study using glycerol and RF in multiple sclerosis-related TN, and idiopathic TN, both procedures were effective with a mean duration to recurrence of 26 months for idiopathic TN and 20 months for multiple sclerosis-related TN. 3 studies evaluate pain recurrence rates with life table analyses. Overall, these studies demonstrate a significant long-term benefit of rhizotomy for TN. Reported recurrence rates concurred, ranging from 31.5% to 60% at 5 years. Today, trigeminal neurectomy is practiced much less commonly than RF lesions. 5 case series focused on neurectomy, and these tended to show short-term relief. 2 retrospective studies and 1 prospective study on the use of either rhizotomy and neurectomy for cluster headache were reviewed. In the prospective study, 83% of patients had immediate pain relief, but also demonstrated a 39% recurrence rate at long-term follow-up. 10 case series studying the use of rhizotomy for cancer pain were identified, the majority of which evaluated the effects of dorsal root rhizotomy for malignant pain of the extremities. The largest series contained 71 patients and was one of the earliest papers. Reported outcomes generally were favorable initially, but faded quickly with time. The open nature of the procedure, the fading effect, and the presence of more effective procedures all contributed to the abandonment of this procedure. Gangliolysis, either percutaneous or open surgical, has been investigated for the control of radicular pain. Occipital neuralgia has been considered to be a radiculopathy of C2 or C3, and as such has been treated with open surgical ganglionectomy. Screening was typically by selective blockade of either the C2 or C3 root, depending upon the location of the pain. A positive response was pain relief appropriate to the duration of the local anesthetic used. The C2 and C3 nerve roots are encased in a dense venous plexus, and surgery to remove these ganglia must be approached with careful hemostasis and clear identification of the ganglion. The surgical approach is conducted via a small foraminotomy. A total of 20 articles on the use of ganglionectomy for treatment of pain were found that met the selection criteria previously indicated. All studies addressed benign pain conditions. 3 were randomized controlled trials. 1 compared RF lumbar ganglionectomies with sham surgery for sciatica. The second compared RF lesions made at 2 different temperatures, and the third compared dorsal root ganglion destruction by doxorubicin with injection in management of postherpetic neuralgia. The remaining articles were case series ranging in size from 3 to 102 patients. In 2003, Gertz and colleagues reported on their study which randomly assigned 83 patients to either RF lesioning or needle placement without RF lesion of selected lumbar ganglion. Evaluators and patients were blinded to the protocol used. Despite adequate power, this study found no statistical difference between the groups. Slappendel and Associates reported in 1997 that they found no difference in outcome between patients receiving RF lesions at 60 degrees centigrade and those receiving lesions at 40 degrees centigrade for cervicobrachialgia. In another study, a case series of 61 patients with sciatica, 59% of patients had markedly reduced postoperative pain at follow-up ranging between 1 month and 15 years. Definite conclusions concerning long-term outcomes are difficult, given the variability in the follow-up data. The remaining studies were small and inconsistent. The procedure of RF ganglionectomy for lumbar and cervical pain has mostly been abandoned. The largest case series evaluated the efficacy of C2 ganglionectomies for occipital neuralgia. The investigators found that 80% of patients had significant relief from symptoms. Unfortunately, long-term follow-up data were unclear, rendering any conclusions difficult. The second largest series of patients with occipital neuralgia compared ganglionectomies performed in patients with occipital pain described as either sharp, burning, jabbing, electrical, or exploding, group 1, or dull, aching, throbbing, or pressure-like, Group 2. Patients in Group 1 tended to have a higher prevalence of a traumatic history and had the better response, nearly 80%. Overall, Group 2 patients had a poor outcome. Follow-up ranged from 19 to 48 months. Other published series on ganglionectomy performed for occipital neuralgia were small and without standardized follow-up data. This procedure, too, has largely been abandoned. One study evaluated sphenopalatine ganglionectomies for cluster headache and found that patients with intermittent headache had a 67% response rate, but those with chronic continuous headache had only a 24% response. Mean follow-up times were 24 and 29 months, respectively. Currently, this procedure is rarely, if ever, performed. In summary, percutaneous facet rhizolysis is the only destructive procedure in the group of procedures directed at either the spinal nerve, dorsal root ganglion, or innervation of the facets for the purpose of relieving radicular pain, occipital neuralgia, or lumbar cervical pain to show some promise of durable pain relief in longer-term follow-up. Dorsal root entry zone, or DREZ lesions, a myelotomy directed to the superficial layers of the dorsal horn, has been performed for a variety of painful conditions, including brachial and lumbosacral avulsion pain syndromes, spinal cord injury pain, and thoracic postherpetic neuralgia. The goal of this surgery is to eliminate what is thought to be the generator of pain located in the deeper layers of the dorsal horn, which contain the wide dynamic range neurons. Traumatic brachial plexus avulsion, as demonstrated on this MRI with pseudomeningocele formation and avulsion of the superficial layers of the dorsal horn, can produce a profound deafferentation pain syndrome and what is often a completely insensate and paralyzed upper extremity. DREZ lesions are performed by surgically exposing the spinal cord, demonstrating the absence of dorsal roots in the affected spinal segments. Lesions in the superficial dorsal horn can be made directly using a microknife and microbipolar cautery or by using a radiofrequency electrode. A total of 32, 27 non-cancer pain and 5 cancer pain case series were obtained for DREZ lesions. No Class 1 or Class 2 studies were found. These reports consisted of between 1 and 124 patients with a wide range of follow-up time points. For non-cancer pain, all studies reported a greater than 50% relief in pain in a majority of patients, and these results tended to be durable. Patients with brachial plexus avulsion injuries and traumatic spinal cord injuries tended to have the best responses to DREZ, whereas patients with postherpetic neuralgia and peripheral neuropathies had the worst. Outcomes for patients with brachial plexus injuries were quite consistent across series, with more than 50% reduction in reported pain levels in from 54 to 86% of patients. Since 2008, 11 studies involving DREZ lesions for the management of non-cancer pain were published, 4 case reports, 6 case series, and 1 comparative study. Only 4 papers were identified that addressed the use of DREZ lesions for cancer pain. 2 were case series that claimed long-lasting pain relief in patients with mixed cancer pain etiologies. Specific follow-ups and outcome measures were not reported. DREZ lesions for brachial plexus avulsion pain are still performed with good success. DREZ lesions for postherpetic neuralgia and peripheral neuropathic pains have been abandoned. DREZ lesions for cancer pain are rarely performed. Lesions of the descending trigeminal tract and nucleus caudalis can be made by exposure of the brainstem and introducing an RF electrode to the depth of the tract and nucleus. This procedure can be used to treat neuropathic pain of the face or facial pain caused by malignancy. 9 pertinent articles were found for the use of trigeminal tractotomy in non-cancer pain, including the oldest article retrieved for this review. No Class 1 data were found for this topic. Instead, all papers were case series. The largest case series was reported in 1975 by Schwartz, who found that excellent pain relief was obtained in 16 of 17 patients. Interestingly, all case series reported good to excellent results even in patients with postherpetic neuralgia. In one series, for example, deep pain was eliminated or significantly decreased in all 6 patients with postherpetic craniofacial dysesthesia. 7 papers were found for tracheotomy in facial pain due to cancer. All were case series, with one exception, an open-label prospective study. In this prospective Class 2 study, a standardized outcome measure, visual analog scale, Karnofsky performance score, activities of daily living, and sleep duration were assessed at 6 months. The researchers reported sustained pain relief in 80% of patients at 6 months. Though the study was classified as Class 2, the number of tracheotomy recipients included was limited to 10 patients. We did not consider this number sufficient to assign it Class 2 evidence for the efficacy of tracheotomy in cancer facial pain. Current literature supports only Class 3 evidence for tracheotomy for cancer pain. Trigeminal tracheotomy and nucleotomy is still performed, although rarely. The next procedure to be discussed is perhaps one of the most important destructive procedures for pain control. Radiofrequency lesions of the anterolateral spinothalamic tract, referred to as chordotomy, have been used for decades to alleviate pain of malignant origin. Lesions are made in the cervical spinal cord at the level of C2 and can alleviate contralateral pain arising several segments below the level of the spinal tract lesion. The introduction of computed tomography, CT guidance, for percutaneous chordotomy by Konpalat in the late 1980s was considered a major contribution to the field of pain surgery. However, use of intrathecal opioids was also introduced at around the same time and gained widespread popularity. Konpalat's use of CT guidance for percutaneous chordotomy made the chordotomy procedure more accurate and safer for the patient. A review of chordotomy studies in patients with non-cancer pain produced 12 case series, published between 1958 and 1990, and 3 case reports, with 2 published in 2012 and 1 in 2017. No Class 1 or 2 studies were found. The number of patients in these case series ranged from 1 to 72, and follow-up was between 1 month and 41 years. Outcome data from these studies generally demonstrated an overall improvement in postoperative patient-reported pain over preoperative values. In general, for studies with long-term follow-up, surgical benefits declined with time. However, determining the statistical significance of these findings was difficult as neither outcome nor follow-up was standardized in the studies. Furthermore, outcome measures were inconsistent among studies, complicating any attempts to make generalized recommendations. The longest follow-up was in a case report of a period of 41 years. The patient was completely pain-free for 35 years, after which he started to experience slowly progressive aching pain. For cancer pain, chordotomy is the invasive procedure most often reported in the literature. 84 papers qualified under our search criteria. Many reports included more than 100 patients, and many had long-term follow-up. A surge in publication followed the introduction of percutaneous chordotomy in the mid-1960s, followed by a gradual decline in published reports and number of patients treated in the late 1990s. 2 prospective trials on chordotomy were identified. One of them used standardized outcome measures, the VAS, a Karnofsky performance score, activities of daily living, and total sleeping hours. There was a statistically significant improvement in all outcome measures over baseline pain levels. The other trial showed average pain scores immediately preoperatively, 2 days postoperatively, and 28 days postoperatively to be 7, 0, and 0, respectively. 3 papers were retrospective cohort studies with survival analysis of pain relief of the whole cohort until death. 5 papers were retrospective cohort studies with large numbers of patients and 6 months of follow-up. There were no randomized controlled trials. 3 case reports were found in the literature in which all patients had complete pain relief postoperatively. Only one systematic review by France and Associates concluded that cordotomy might be safe and effective in treatment of cancer pain, but that more reliable evidence is needed to aid in decision-making. Despite the heterogeneity of outcome measures, the vast majority of studies reported excellent lasting relief after cordotomy within the context of cancer longevity. Reported cordotomy outcomes in patients with cancer pain contrast with outcomes in those with non-cancer pain, in whom pain relief was moderate, short-lived, and often complicated with dysesthesias. Within the medical literature, there is limited Class II evidence for cordotomy as an effective treatment modality in cancer pain patients. Cordotomy for cancer pain is still performed. Midline, or so-called extralimniscal myelotomy, is usually performed either with direct myelotomy or RF lesion directed at the anterior commissure after surgical exposure of the dorsal spinal cord. The original concept was to disrupt the crossing fibers which form the spinothalamic tract, producing bilateral segmental analgesia several segments below the lesion. Cervical midline myelotomy has been found to produce bilateral analgesia below the level of the lesion, and it has been suggested that disruption of the postsynaptic dorsal column pathway may be its mechanism of action. 3 articles examining the use of myelotomy in non-cancer pain were found. These were small case series, 3 to 14 patients, with variable follow-up periods and pain etiologies. The largest series reported that 64% of patients experienced a complete or marked reduction in deep background pain. For cancer pain, 21 papers were identified. These articles were all case series and included papers about commissural as well as extralimniscal myelotomy, both open and percutaneous. With the exception of 2 papers, most reports involved a small number of patients. Outcome measures and follow-up periods were heterogeneous. In general, reported outcomes after myelotomy were less favorable than those after cordotomy. However, a consistent observation was that myelotomy was most effective in treating midline visceral cancer pain syndromes, that is, pain from cervical, pancreatic, or gastric cancer. The current literature supports only Class III evidence for myelotomy for pain relief, and midline myelotomy is rarely performed. Unilateral stereotactic RF lesions can be made in the spinothalamic tract at the level of the midbrain to produce hemianalgesia in cases of localized pain related to malignancy. We reviewed 9 relevant articles concerning the use of mesencephalotomy for non-cancer pain. All of these articles were case series, and most had relatively small numbers of patients. The latest publication reported the effects of lesions made in 1 of 2 locations in 27 patients with central pain following a stroke. Long-term pain relief was produced in 75% of patients with lesions created at the level of the superior colliculus, although with significant eye movement side effects. These side effects were reduced with lesions adjacent to the inferior colliculus. Long-term pain relief was achieved in 58% of patients who received the adjacent lesions. Follow-up was between 3 months and 5 years. In a separate study, good pain relief was produced in 23 patients with thalamic syndrome and tabes dorsalis, followed up for 3 to 70 months. Mesencephalotomy and pontine tractotomy for cancer pain were reported in 8 papers. 7 studies were case series, and 1 was a case report with variable outcome measures and follow-up. Outcome varied from extreme success in 92% of patients until death to very poor success, lasting pain relief in 1 of 12 patients. There was agreement on frequency of side effects, specifically those related to ocular mobility. Mesencephalic tractotomy for the purpose of pain relief has been abandoned. Lesions directed at the medial nuclei of the thalamus, centralis lateralis, centromedian, and parafascicularis have been used to disrupt the projection of the spinothalamic tract to the neocortex and striatum. All published articles describing thalamotomy for pain were limited to small case series with heterogeneous patient populations. The largest case series, of 85, was published not in a peer review article but in book format, and so is not included here. However, the investigators did describe a subset of patients from this series in an earlier report. Follow-up, outcome measures, target site, and pain etiology were inconsistent within or among series, making definite conclusions difficult. Doherty and colleagues and Tasker have provided thorough discussions of thalamotomy. 16 papers on thalamotomy in cancer pain were found. All were case series with variable outcome measures and follow-up. Most reported lasting benefits in more than 50% of patients. In some instances, bilateral pain relief was obtained with unilateral thalamotomy. Effects tended to fade with time and were often accompanied by persistent psychiatric complications. Medial thalamotomy is rarely performed. Cingulotomy, a lesion of the cingulate gyrus and cingulum fiber tract bundle, is considered a psychosurgical procedure, the goal being to reduce the patient's affective response to pain, that is, to reduce the behavioral reaction to pain by reducing anxiety, fear, and bothersomeness. A total of 14 original case series and 1 case report focusing on cingulotomy for non-cancer pain were identified on the basis of the inclusion criteria. Because the largest case series described in the literature was not published as a peer-reviewed article, it is not included in our analysis. No Class 1 or Class 2 studies were identified. Reported case series were small, the largest one describing 36 patients. Overall, only 2 papers used a validated outcome measure such as the VAS, and only 2 papers had a common diagnosis for the series. Different follow-up periods and variable outcome measures were used, making comparisons difficult. And for most series, reported outcomes were also variable. Also, the majority of the reports were published before 1980. Abdelaziz and Cosgrove provide a detailed description and summary of published case series. After elimination of redundancy, 8 papers qualified for the criteria of this review and addressed cingulotomy for cancer. All were case series with small numbers and heterogeneous patient selection. In a later report, 50% of patients had some pain relief for up to 6 months. Results in the other papers were variable, ranging from 10% to 50%. In a separate paper, 71% of patients had maintained pain relief for 3 months, but no follow-up was done at 6 months. Cingulotomy for pain control is rarely performed. Lastly, sympathectomy has been used to disrupt en passage fibers of pain-transmitting neurons, A delta and C fibers, which transit sympathetic ganglia, primarily the celiac ganglion in the retroperitoneum, which serves the pancreas and other viscera. A Cochrane systematic review on sympathectomy for non-malignant pain syndromes, specifically for neuropathic pain syndrome, was published in 2003. The review criteria the investigators used included all randomized clinical trials, controlled clinical trials, observational studies including cohorts and case-controlled studies, and relevant retrospective reviews of patient charts for a total of 223 titles and abstracts. Only surgical sympathectomy, cervicothoracic or lumbar sympathetic chain ablation or coagulation by open, endoscopic, laser, or radiofrequency, or chemical sympathectomy by phenol or alcohol solution injection of cervicothoracic or lumbar sympathetic chain were included. The review showed that treating neuropathic pain with sympathectomy is based on very limited evidence. An additional publication, published in 2012, reported on sympathectomy for complex regional pain syndrome, or CRPS, and described achieving adequate pain relief for a mean duration of 3.2 years. As to sympathectomy for malignant pain, our search identified much the same information. A meta-analysis of neurolytic celiac block, the most common form of sympathectomy performed for cancer pain, was identified along with 7 additional papers addressing either celiac block or other forms of sympathectomy. These studies generally focused on patients with midline pain from visceral malignancies. The meta-analysis identified 2 Class 1 RCTs demonstrating the efficacy and safety of celiac block in the treatment of pancreatic as well as upper abdominal visceral malignancies. Of the other 7 papers, one was a Class 1 RCT for sympathectomy for inoperable cancer pain, in which excellent pain relief was achieved for up to 3 months. 2 others, a Class 2 prospective randomized trial involving 65 patients and a prospective open-label Class 2 study involving 58 patients, both demonstrated statistically significant pain relief at 6-month follow-up in patients with pancreatic cancer. Sympathectomy for non-cancer pain has limited supportive evidence, but celiac block for pain due to upper abdominal and pancreatic malignancies is still performed. High-quality data to support ablative procedures for pain control is largely lacking. Most reports provide Class 3 evidence. Study design is poor, as is the consistency of follow-up and outcome measures. There are better studies in the anesthesiology literature, but most of this data relates to percutaneous procedures. Several areas of ablative pain surgery still present intriguing possibilities for further study. Clinical experience with DRES lesions for brachial plexus avulsion pain is very favorable, but a prospective randomized and controlled trial would present more compelling proof of efficacy. Likewise, commissural extralemniscal myelotomy has shown good results for visceral cancer pain and should be studied further. The evidence to support chordotomy, while not meeting contemporary standards of evidence, is positive. This procedure in particular could be resurrected by a carefully designed prospective trial. Future studies should consider the issues of being prospective, randomized, and controlled. Adequate blinding is essential since placebo effects are prevalent and pain is a subjective experience. Validated outcome measures should be employed, and subgroups should be analyzed for responders. Thank you for your interest in the issue of ablative neurosurgical procedures for pain control, and we hope you have gained meaningful knowledge from this presentation.